just a couple of updates maybe. So one, the gene expression profile test, as you may know, requires tumor tissue. The ocular oncologists or the retina surgeons who are the diagnosing physicians for you are largely well aware of it in the U.S. I think all but 2 or 3 centers use this assay or offer it as one of the standard options going forward. So hopefully we aren't missing patients who want to think about, is this information I want to have to be able to help manage my treatment plan going forward? So I think that's probably less of an issue. The assay that we made available in early 2010 was based upon this first study called COOG, C-O-O-G, which was really the first protocol that the National Cancer Institute had funded after the large COMS study in the 80s and 90s, and that was led by Dr. Harbour and 13 other centers here in the US and Canada. And that database formed the basis of a sort of class 1, class 2 signature. As part of that study set, he also began working on those patients that we see that there are these patients who sometimes have a class 1 signature, who have what appears to be an increased risk of metastasis a little bit later in the out years, as Dr. Harbour went through this morning. And the first thought that he had was, well, maybe the class 1 signature is missing class 2 patients. Maybe it's just kind of a false negative rate. So we have this sort of low risk of background metastatic risk in a patient who's class 1, and maybe that's really a class 2 patient that the test just missed. And so he embarked on some work in kind of 2010-11 to say, is that really the case or not? And what he found was that in the few cases in the research set that he had developed of patients that had a class 1 tumor call that had gone on to have a recurrence in their predominantly liver areas, we know, actually didn't look like class 2 patients. They had kind of normal chromosomal status, they had normal BAP1 status, and that's what led him down this pathway of saying, maybe there's a different process here. Maybe there's multiple potential processes that might lead to metastatic disease in uveal melanoma. And that led to, as he talked about this morning, I think, this first sort of class 1A, 1B signature. And the limitation of that work was he was really limited because of the data that he developed to saying, are those 12 genes that are discriminating between a class 1 and class 2, within those 12 genes, can I tease out some of these late metastasizing class 1s? And he was successful with that, and that's what kind of led us to this kind of class 1A, class 1B, class 2 dialogue. Now the question was, which he, once that data was validated, we said the right thing to do from a patient care standpoint is to say we could wait 7 or 8 years, let more data develop to go ahead and validate just how strong a class 1A or 1B signature shift was. But the reality of it is that this is a rare cancer. And we have data which is suggestive of saying, hey, the majority of cases that are metastasizing, which is few, that are class 1, end up being a little different, and we should go ahead and let that information be known to patients and doctors, as opposed to saying, let's wait until it comes downstream. So we made that shift around 2012, I think, to begin reporting class 1A, class 1B, and class 2, as you know the results today. We, since that time, have had several other data sets that have been presented or published. So since I think the ENA meeting occurred in Cleveland last year, you had, I think, 2 presentations at the American Association of Ophthalmology, one from the University of Michigan, a publication coming out of the University of Cincinnati, a prospective study that we embarked on ourselves in 2010. And those 3 studies essentially confirmed that a class 1A signature is really quite a low risk of metastatic risk, but there is a risk, of course, nothing's perfect. A class 1B seems to have a sort of latent risk, and a class 2 signature is this very strong phenotype saying, I've already left home and I want to act in your body. And that's kind of held up very nicely. So I think that's that part of that. The other part of it, which we've had lots of questions on, and I think, I remember, we asked earlier was, what's going on with this PRAME thing that's been talked about here and there? And I don't want to supersede what Dr. Harbour and the medical oncologist will go ahead and talk about later on today, but that was looked at, and it looks like PRAME may be a marker for kind of a class 1B signature, or class 1B is a marker for PRAME, however you want to view that. It was not in the original 12 gene signature from the gene expression profile test, so it's a different gene we have to measure. We've spent the last maybe 7 or 8 months in the laboratory in Phoenix working through validating PRAME on about 950 de-identified cases, and that analytical validation was completed earlier this month, so we expect going forward sometime in October we'll be offering up to your physicians or to physicians for patients diagnosed in the future the opportunity that if they want to go ahead and order the DecisionDx UV melanoma assay, they can do that. If they want to order PRAME reflexively or as part of it, they can do that too. We're not going to report it as one test report. We're going to issue a class 1A, 1B, class 2 report, and then provide a separate report on PRAME positivity or negativity with some very soft language around what that may or may not mean. That's predominantly because, as you heard Dr. Harbour talk about, the whole COOG-2 study, which is kicking off now, is one of their questions is to say, how important is PRAME prognostically going forward, or is it predominantly important in terms of potentially helping us identify a targeted therapy approach from an immune response standpoint that may be effective in managing metastatic disease. So that's just an awareness of what's happening going forward. Now, you didn't quite ask that question. We were talking earlier, but the question is, for those of us who were tested in the last couple of years, is it worth considering working through your ocular oncologist and saying, I'd like to know what my PRAME status was in my eye tumor? I think that's a discussion to have with your ocular oncologist, one. And two, if the decision is made to say, yes, we'd like to pursue that, one is to say, well, not everybody probably needs that. So for instance, if you ended up getting a class 2 gene expression profile outcome, at least in kind of the fall of 2016, that might be interesting to know, but is it going to really adjust what you may be doing either from a surveillance or management standpoint? There aren't really clinical trials opened up widely that would use that data somehow for enrollment criteria. So again, it might be something interesting to have, and for those of us who like a lot of data, well, I might say I want it anyways because I want to understand what I'm facing. But I would say that there are some patients that probably wouldn't be appropriate to have that considered, but again, that's for your physician, you to make that determination. Now, if we have residual specimen or tumor specimen from the biopsy that was sent to us with your original testing, we will go back and find that, and we will test it upon that request coming in separately. If we don't have any residual tumor tissue, we can't test it. So I want to set some expectations on a few things there. One of them is to say, we'll go ahead and roll out PRAME testing as an option going forward here in October. For patients who have been tested recently, if we have residual tumor tissue, I think the first thing is to discuss with your ocular oncologist, is this something that's really going to help us decide something differently? And the answer may be absolutely not, or maybe absolutely will. And so I would just kind of caution you to not get excited about just having the next shiny new car, I guess I would say, because it may not be a car that's worth driving. Is that fair? Secondly is we are working on finalizing validation, but this will take another couple of months because the sample to go ahead and complete validation are just harder to secure in a rare tumor, but we're going to probably be rolling out here after in 2017 a 6-gene mutational panel assessment on primary melanoma tumor tissue. It'll be something that we'll offer alongside of the DecisionDx UV melanoma test. Again, I think it's going to be something which will provide more information as opposed to be an instead of opportunity. And the clinical value of that, I think, is something which is going to be really the focus of Dr. Harbour's COOG-2 studies. So again, it's information that, given how precious your sample is, we feel that when we can do it and report it honestly and accurately, we should do that. The actionability may be a couple of years off, but that's the service we can provide to you from there. I got started early because I figured everybody was caught in the elevator. So those are kind of the only couple of comments I was going to kind of offer up, as to say, one is I want you to get closer to staying on schedule, so I pulled all my slides back. Two is to say, I think the sort of decision you may have had about, do I want to have testing performed, you've hopefully had a chance already to make that choice before coming here. And then three is let you know about those couple of future opportunities to provide improvements of the assay. And with that, if there are any open questions, anybody else would care to go ahead and ask Kristen, Dr. Harper, myself, that'd be fantastic.
How are we coming up with the 6 genes you're going to isolate?
Focus on. So the question was, how are we going to come up with those 6 genes we're going to be focusing on? You want to?
Yeah, so these are the main driver genes in uveal melanoma, and the GNAQ, GNA11. There's now 2 other genes that are what we call the initiating genes that have been identified that we think are the mutation that actually starts the whole process going. They don't make the tumor fully malignant, but they are required to start the process. So that's one set of genes, and GNAQ, GNA11 account for 85% or so of the initiating mutations. So most people are still focusing on those 2 in terms of the initiating genes. The 3 that I think are more interesting and helpful are what we think of as the progression genes, and that's BAP1, SF3B1, and EIF1AX. And these tend to occur in mutually exclusive manner, so you tend to get one but not the other 2. The BAP1 mutation is associated with high risk, that's class 2. The EIF1AX mutation is associated with very, very low risk. If you have this mutation, it seems to be protective for the most part. And then SF3B1 is kind of the one in the middle. It's kind of associated with the frame expression, class 1 frame expression. So that's how we pick these genes. These seem to be, we've now looked at over 150 separate ocular melanomas with what's called deep sequencing, next generation deep sequencing, using the best technologies, and really no other driver mutations have shown up. Driver meaning they're key. You can find other mutations that may be only in one tumor out of 100 or 200 or 500. That's not going to really help develop a new drug if only one patient in 500 has a mutation. You want something where 10% or 20% or 50% have a mutation. And that's what we call driver mutation. So that's why those genes were chosen.
Anything else? Perfect.